I think there's also an opportunity for some patients to talk to their team about timing of the vaccine. So that way, depending on where they're at in the course of treatment, if there's an opportunity to pause or delay the start of treatment or interrupt current treatment, then that might be a good approach to potentially increase their response to the vaccine.
On this episode of Cancer Buzz, the effect of the pandemic on managing the treatment of chronic lymphocytic leukemia, or CLL. What you need to know is next. Welcome to Cancer Buzz. I'm your host, Summer Johnson. Chronic lymphocytic leukemia is the most common leukemia in adults, typically diagnosed at an early stage in older patients. A heterogeneous disease, CLL can either be a slow-growing cancer with a treatment regimen that involves watchful waiting, or it can be a more aggressive disease that requires a different therapeutic approach. Patients on active treatment for CLL can be severely immunocompromised, which is of course a big concern for providers during a global pandemic. We set out to learn how cancer programs are adapting to keep these patients safe despite pandemic-era restrictions. Cancer Buzz spoke with Christopher DeAndre. He's a physician assistant at the Cleveland Clinic who specializes in lymphoma patients.
I would say, generally speaking, most patients who have a diagnosis of CLL tended to be older than age 50, and I'd say probably the average is closer to 70. Most of these patients tend to be male. However, I think you do see many CLL patients, and so from my experience, the patient population is quite diverse. I would say the most concerning feature relative to CLL patients is that CLL patients have an inherently higher risk for contracting infectious diseases simply because it's a product of the diagnosis in that their immune system, their B cells, their humoral immunity is functionally impaired, and that can be a major comorbidity with patients with CLL. So I would say that it's not maybe specific to COVID-19, meaning that they're not necessarily at higher risk for COVID-19 infections. They are at higher risk for all types of infections, including COVID-19. So what keeps me up at night is patients who are diagnosed with CLL and who may be on active treatment, thus further suppressing the immune system and thus increasing their risk for contracting COVID-19. Unfortunately, we did have a few patients in the last year who, on active therapy or completed recent therapy, that then contracted COVID-19 and had a very adverse outcome that actually led to some fatalities, unfortunately. So if you ask me what keeps me up at night or what's most concerning about CLL relative to this pandemic, it's those patients that have this diagnosis that require treatment, that are on active treatment, and that are, inherently at risk for very serious adverse outcomes should they contract COVID-19.
What advice are you giving patients about, they're seeing everything open up around them? What are you telling them? And then what's your advice about getting the vaccine to patients?
So patients ask this often. This is a great question. I'm glad you asked it because certainly now as rates of vaccination are increasing, vaccines are available to most adult patients at this point. We are telling our patients to continue to practice the CDC recommended guidelines to mitigate their risk of contracting COVID-19. However, I also emphasize, again, the risk for other infectious diseases such as influenza or pneumonia, and the need to continue to practice these recommended behaviors of social distancing, mask wearing, and avoiding public spaces and gatherings whenever possible. I think that's the challenge that we're going to continue to face as we start to get more, I don't know if comfort is the right word, or we start to maybe get more lax in terms of wanting to get back to a normal life, and with people now being vaccinated. But I think with our patients, I emphasize this need to continue to practice those behaviors to protect themselves not only against COVID-19, but against all infectious diseases, given this innate risk that exists as a result of their diagnosis, whether they're on long-term follow-up care, whether they're on, just initial surveillance and are treatment naive, or especially those folks that are on active therapy. I try to err on the side of caution. As far as the vaccine goes, we are recommending that all patients get vaccinated, of course, excluding anybody who may have a history of a very serious allergic reaction to vaccines or ingredients within vaccines. That's a separate entity, but that only applies to, I would think, a very small percentage of patients, and most patients should be encouraged to get vaccinated.
So are there any things to keep in mind with the vaccine and immunocompromised people?
There is data emerging that shows that patients with CLL, even those that are maybe treatment naive or those that are post-treatment in long-term follow-up care, that their response to the vaccine is likely going to be less than somebody else's who has never had CLL and never been treated for cancer. And that actually sort of makes sense when we think about the pathophysiology of CLL. So CLL is a dysfunction of B cells, in that you have this excess population of functionally incompetent B cells that are unable to do things that normal B cells are able to do, such as produce antibodies. And that's what's required when somebody gets vaccinated. So the vaccine is administered, and the humoral immune system recognizes that this is a foreign invader. Thus, the B cells, part of their function is to produce antibodies to fight off this believed to be foreign invader. And so when you have a disease that functionally inhibits the B cell signaling pathways and response, it makes sense that these patients may not have as good of an antibody response to vaccines. Now, there's data out there that suggests that it can range anywhere from 0 to 50%. It really depends, but I think the bottom line is we are recommending all patients get vaccinated against COVID-19 in an effort to provide them some protection. We don't know what that's going to be with every patient, but some protection is better than zero protection. And that's the approach that we have been taking. I think there's also an opportunity for some patients to talk to their team about timing of the vaccine. So that way, depending on where they're at in the course of treatment, if there's an opportunity to pause or delay the start of treatment or interrupt current treatment, then that might be a good approach to potentially increase their response to the vaccine.
Let's talk now about the course of treatment for patients with CLL and how that's kind of evolved and changed for you guys during the course of the pandemic. Chris, how has treatment changed? How was your clinic able to adapt for these patients to keep them safe and sheltered in place because they're immunocompromised? And then how have you seen that treatment evolve over the course of the last year for them?
So if we're talking about the evolution of treatment since the pandemic began, I think there's some similarities, but maybe some differences. The similarities being that those patients who do not require treatment, we will continue to do surveillance, encourage continued follow-ups, or perhaps have adjusted our practice to reflect maybe more virtual visits or more just simply assessing their blood counts and not necessarily bringing them into the clinic. So I think that's one way our practice has evolved. However, we do try to minimize treatment when it is not necessary and keep those patients on active surveillance, as early treatment has been shown not to improve progression-free survival or overall survival. So there's a group of patients that can be watched and waited. Now, those patients who maybe have required treatment for their disease over the course of this last year through the pandemic, I think we've evolved in a way of taking into context the course of the pandemic, vaccination availability, and need for treatment. So this becomes more of a case-by-case basis where I think it's important to discuss these things with each patient individually about the risk-benefit of perhaps delaying treatment, if possible, in that you're allowing the patient to get vaccinated so they may be more protected than they would be if they were vaccinated during treatment or after treatment.
I'd like to shift now to talk about newly diagnosed and upstaged cancer. So that's been a big topic for the oncology community, right? Over the past year is delayed screenings, delayed treatments are just going to result in perhaps more upstage cancer when we do see these patients back, when they start returning to their PCPs. Especially, it dawns on me, especially with this group, right? Because isn't CLL normally found during routine physicals?
Correct. That's a common way it's diagnosed, yes, is that, routine blood work has shown some abnormalities and then the patient gets diagnosed. So yes, I would say many times patients are not necessarily symptomatic at the time of diagnosis.
So have you seen at the Cleveland Clinic an influx of newly diagnosed patients with CLL?
No, I don't think that I can say that we've seen a sudden influx of new cases or new diagnoses. I think the potential there exists now that we are in 2021 and we have a year of this pandemic under our belt, as patients perhaps now start to return to primary care. So I think that's a possible scenario that we could see. And I think that goes for all types of diseases, though, as folks, put off screenings and, maybe routine care follow-ups due to fears of contracting the virus by coming to a healthcare facility. I think that, let's say the jury is still out on that one, but I could see a scenario this year in the coming year or two where you do start to see more influx or sudden popping up, if you will, of these diagnoses. But I think that applies to all diseases, not just cancer, that, maybe would have been caught early and you wouldn't have seen a spike in new cases because had we not had the pandemic, folks would still be going to get their routine health care as they previously were. So I think that's something we could certainly see in the next year.
Please check out the show notes for more information related to today's show. Thank you for supporting Cancer Buzz. If you enjoyed this episode, there are 3 ways you can help us continue producing the show. You can give us a rating and a review on Apple Podcasts. You can share the episode with a colleague, and you can share it on your social media channels. Next up on Cancer Buzz, a 2-part mini podcast series on one of the most pertinent issues impacting cancer programs today, the impact of COVID-19 on revenue optimization. You won't want to miss that one. Until then, for the entire Cancer Buzz team, this is Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.